This is Terms of Reference. I'm your host, Stephen Laddick. Similar to essentially any other industry, the problem of efficiently collecting project or program level data that can be readily crunched, analyzed, and ultimately used by managers for decision making has been and will continue to be a conundrum for the development and humanitarian aid community for the foreseeable future. I've often heard the frustration from professionals in the field who wonder out loud why we haven't been able to pull together one or perhaps just a small set of technology solutions that can be used for monitoring any output at any time. Now, beyond the actual technology itself, which is a huge set of problems all on its own, a key part of this conversation is the question of how to implement such a solution in a way that is not only relevant for a project, but also for the workers tasked with the actual data collection. And then going further, how do you build a tool that doesn't add a massive time burden to those who are already tasked with the impossible? Dimagi is one company who are attempting to solve these problems. And today's guest on the 110th Terms of Reference podcast, Mohini Bhavsar, is on the front lines for them in Dakar, Senegal. She is Dimagi's Deputy Regional Director in West Africa, and she has extensive experience supporting mHealth, or mobile health projects at scale. Currently, she provides strategic guidance for scale-up and trainings for Dimagi's largest mHealth projects in West Africa, including a partnership with Terre des Hommes in Burkina Faso for the implementation of a tablet-based clinical diagnostic tool for EI-MCI protocols, a pregnancy danger sign and referral management application developed with Africare in Senegal, and a multi-pronged healthcare services and stock management application developed with URC for community health workers in Benin. She has worked closely with partners such as Catholic Relief Services, World Vision, Save the Children, and the Indian Council of Medical Research. Prior to Dimagi, Mohini worked with the Tula Salud in Guatemala to evaluate and support scale-up of their mHealth initiatives. I spoke with Mohini in Dakar. Hello, Mohini. Thank you so much for being on the Terms of Reference podcast today.
Thanks, Stephen. It's great to be here.
Mohini, I understand that you are nowhere near me right now. Where are you sitting right now?
Yes, I'm based in Dakar, Senegal.
Awesome.
Today I'm working from home, so I'm based in my house.
Yeah, excellent. So I don't think we've had anybody from Senegal on the show before. You're our first. This is fantastic. You work for an organization called Dimagi. Why don't we just kick off our conversation about with having you tell us a little bit about that organization, what the organization focuses on, but then maybe in particular what your work is about.
Okay, great. So Dimagi is a B Corporation. We're based out of Cambridge, Massachusetts, and we have country offices in India, in Cape Town, in Dakar, Senegal, and we have a few folks working out of Myanmar and Guatemala. And we build mobile technology solutions for low resource settings. And a large part of our applications are built for community health workers in developing countries. So often national governments and ministries of health have set up programs whereby they've trained, one or two individuals. Most of the time they can be women, but they can also be men from a community to deliver, primary healthcare services to their community members, often pregnant women and children between 0 and 5 years of age. So we're building mobile apps for them to be able to register, track, and deliver health services using, automated checklists, counseling prompts, which use audio, images, and video, and things like that. So they're collecting data, and they're also delivering services through these automated mobile job aids, essentially. And so these health workers are able to then send that data using mobile internet to our cloud server. And then on the other end, supervisors and program administrators and even ministries of health are able to see that data come through real time. Actually, for the most part, it's near real time because, internet is often a challenge in the places we work at. But the, feedback loop is greatly reduced. And now program administrators are able to see, the kinds of health issues that are being present in the villages and communities that they're trying to deliver services to. And they're also able to see the performance of health workers, right? So they're able to see health workers registering, pregnant women, how many pregnant women are they registering, how many children are they registering, and how often are they following up with pregnant women and children, and whether their delivery of services is at the level that they're hopefully expecting. And so that in essence is what we do. We also work in other sectors like agriculture and education, whereby even in these sectors, there are frontline workers. And so, you might have an agriculture extension worker or an agriculture cooperative, for example, that may be in need of a mobile technology solution to collect data or track, harvests, or track the activities of a farmer, or track the activities of a training that's given at an agriculture cooperative. So they're also interested in using mobile apps, and we work with groups like that as well.
Step back for just a second. You started off with something that's very interesting. You're a B Corp. What does that mean?
So B Corp is a corporation that has a social mission, right? So we're a business that needs to be financially viable, but we also have a double bottom line, which is impact. And so Dimagi's mission statement really exemplifies this. So, our mission statement is impact, team satisfaction, and profit, in that order. And so above all else, we will prioritize impact and follow through with the social mission that we have. We want to be delivering low cost technology and low resource settings, and we always hold ourselves accountable to that.
Where was the origin? Where was the passion for this organization founded? I mean, working in low resource settings, if you're a mobile app developer, there's an awful lot of consumers out there that would be, that are interested in being served with applications and those kinds of things. So where did that come from? Do you know?
Yeah, the organization was founded by three folks out of MIT Media Labs who are working in India, as well as we had some work in Tanzania, which were some of our first projects. And I think our theory of change is that supporting health workers do their jobs better improves the quality of care and improves the quality of health and health outcomes at the village level, at the community level. So we want to be able to enable the change agents, the folks that are delivering care with the best of our ability using these mobile job aids. And then our hope is that enabling these people with the right tools will lead to better health outcomes. And we know this because any government or any country that has launched a community health worker program, with or without mobile tools, have seen improvements in health outcomes. So we know community health workers themselves need to improve health outcomes. We're just sort of pushing the game a little bit further and enabling them with these tools that will hopefully help them do their jobs better.
So talk to me about that for a bit. So there's lots of mobile app providers out there, especially at the community health worker level, or at least I think there are. Do you find yourself in a really highly competitive space? And what is it that you feel that you do different or better or faster or cheaper or more profoundly that others don't, and the reason why they would choose Dimagi?
Yeah, I know that's a really great question, and it is really exciting to see the ICT for D space is the kind of ICT for development space sort of growing with lots of different tools out there, mobile tools. Every platform has, their core features or functionalities that they support and their core area of expertise and whatnot. I think Dimagi's platform, which is called ComCare, is different and unique because our ability to do longitudinal tracking, right? So our tool isn't just data collection. You can actually register something, and often it's a pregnant woman, or it's a child, or it's a farmer, or even in some case it might be like a water point, like a borehole, and you're tracking that over time. So we have this offline case management functionality, which really sets our tools apart from the others in the market, and so that is what enables, the user of our apps to go back and follow up on their activities in the past and be reminded of visits that they should be making in the future and things like that. Or it allows us to have checklists in the app that are kind of personalized for that particular case, right? So like a health worker might have a pregnant woman that is in her third trimester, and they might have a pregnant woman in her app that's the first trimester, but each of those women need a different kind of care, different level of care, right? They need to be adopting different health practices. They need to be reminded of a different antenatal care visit. And so with the longitudinal case tracking, that's what makes that possible, to have that personalized care. The other piece that's really unique is that our platform is configurable by non-developers. And that's really what drew me to Dimagi about 5 years ago. And
I assume that means that you're not an IT geek?
I'm an IT geek, but I'm not a developer. I don't have a computer science background. I studied like in a
That's interesting. You
technology
you can you
school
can you
for a
can
year.
you characterize yourself as a as an IT geek, but a non-developer. I like that. Again, that's maybe that's a new nomenclature that I just got to get used to now.
Yeah, and I think that's what we're trying to do here, right? Like we're creating a platform that allows non-developers who may be experts in programmatic areas, right? Like they may be health experts, they may know everything about crisis management, they may know everything about maternal and child health or WASH, water and sanitation. And so enabling those people who are the programmatic experts to build apps, and giving them the opportunity to learn how to use our app builder, which is has a drag and drop interface, and you can do the case management stuff on your own. You can create your surveys and whatnot on your own without having to sort of rely, a developer per se. We have developers, of course, based out of Boston and Cape Town, who build the platform, which in a way that enables others to build their own apps. And what's amazing about this is that like 50% of our projects are self-start, right? There are people like me who like don't have computer science backgrounds or aren't developers building apps, themselves without
So
writing
give
a
me an
single line
example
of
of that.
code.
Like what's an example of like a self-start? First, what does that mean? That somebody has just downloaded the ComCare system and they're like, "Hey, I'm going to use this for something," or
Yeah. So what it means is you can sign up on our website. So you go to like, comcarehq.org and you create an account and you can take a course online. We have these e-courses that are free and you can take them and learn how to use ComCare. And then so, you spend some time learning how to, use the tool and you can build your own application. So you can create your own questions. You can kind of like SurveyMonkey, right? So like SurveyMonkey or like Google Forms, but like for more complicated apps, mobile apps is kind of what we do. And so you can just sign up on our website, build your own app, deploy it. So like put it all together and then install it on your smartphone or on your Java Nokia phone or something like that. And there's like a number of actually organizations in West Africa, actually, surprisingly, we found a lot of groups here that are self-start. So maybe they've like emailed us once to like ask a little bit about our software and how it works. They've spent their time like learning how to use our tools, looking at our documentation online, and spend a significant amount of time learning how to use it. And they ask us questions on our Google Groups forum. It's a free community forum, and sometimes Dimagi answers, and sometimes other self-started people answer each other. So it's a really nice community. And then they've launched their apps, and they have people collecting data in ComCare apps, kind of without too much support from Dimagi or no support from Dimagi.
wow, that's fantastic. It's great to hear that you're sort of this ecosystem. How big is this ecosystem? I mean, are we talking 100,000 users, a million users, 2 million, 10 million, 5?
Oh, I should have these numbers in memory, but I actually don't. I have the latest I can tell you is that we have about 300 projects in over 50 countries around the world, and of those, like 150 or so are self-start, and we probably I think we've definitely surpassed. Well, I'm trying to think how many users we have. I actually don't have all the numbers. Maybe I can get back to you on that
Sure, no worries.
later.
Do you have a particular story that you love, or a particular, maybe it's a self-start story, or maybe it's another, something that you've corporately that you started a project where a real change has happened, or a real difference has been made, or there's like the aha moment happened?
Yeah, I've worked on a number of projects in India. So prior to moving to West Africa, I was in India for about 3.5 years working on Dimagi projects there. And I've been working in a project in Koshambi with the British with Catholic Relief Services. And with them, we built a maternal and child health application for ASHA workers. In India, the health workers are called ASHA workers. So this project's been going on for like the past three years or so, and we have about maybe a little over 200 health workers using ComCare apps to track moms and babies. It was really great because I think when I first started working on that project, it was like probably one of the first projects where we were learning how to design a maternal and child health application, and we had some great counseling content on there where that was recorded by the health workers themselves. So like, we found like some of the best speakers in the villages and that were health workers, and they came and recorded all the messages. So, it was like health workers recording counseling messages for other health workers to play to their communities, during a consultation. And so that was really awesome. And there's a really great story there where we, learned that, we came in with a design, right? Like we came in with a design whereby like, okay, there's these like 12 counseling messages that need to be given to, that health workers need to talk about with pregnant women, at different points in their pregnancy cycle, at different trimesters. And, the checklist itself was very long because they were asking questions on what services the pregnant woman had completed, whether she's taking her iron pills, whether she's eating, green leafy vegetables like 4 times a day and things like that. And it was just long. It just like made the counseling visit like 40 minutes or 30 minutes, and health workers during our field testing kind of came up to us and said, hey, you know what? Like, we really only want to talk about one thing, during our consultation. And we'll really talk about it in a deep way and like focus on that subject. Like, is there a way you can design this app so that we can reduce the consultation visit and just like sort of make give us more choice basically to talk about what we want to talk about, right? Because like they're like pregnant women get bored. Like women get bored hearing the same old messages every single visit, and so we want to like change it up a bit now and then, and so it was a good lesson for us for automation, like how to actually build in. Here we were thinking all about automation, but we needed to build in flexibility.
Don't we see that kind of as a classic, or it sounds kind of like a classic data thing, right? Where it's like more is better. The more data we have, the better it is. The faster the app works, the better it is. And here you are completely characterizing a slow approach, essentially, right?
Exactly.
It's like a slow roll, basically.
Yeah, it's what it really is like testing our assumptions, right? Like, do we really need, first off, all this information that we're collecting? And then B, like, the information that you're collecting doesn't need to be sort of displayed all the time or in the way that you imagined it. And
well,
that's
you
why
even
it's so
said as well,
important
it's also what assumptions have we made about the person that we're
exactly
helping, right?
Exactly.
Because you said they're getting bored, they've heard the same messages, these kinds of things, and that's a wake-up call as well, I think.
Exactly, it is. And I think what's really great is when we invest in user-centric design. So like the ICT for D space, we'll call it user-centric design, as well as like the IT space in general. At Dimagi, we call it designing under the mango tree because we're often like in the field, in the village, like under a hut or something, like designing these things with community health workers. Exactly, yeah. Who doesn't? Yeah, and like so like when we invest in that level of field testing, we can really understand that our assumptions aren't always, almost never right. And it's important to include the end users in the design of your product. And so that's an important lesson. There's a similar story like that from our work in Senegal. So we were designing an app for an organization, Africare, in Senegal. And they have about 300 health workers, matrons, in Senegal using ComCare. And again, for maternal child health tracking. And we developed a referral system for them. So like a health worker at the community level can do a consultation with a pregnant woman and identify danger signs, right? And like if we can identify danger signs that a mother is experiencing early on, then we can reduce, maternal mortality, and we can, follow up with prevention strategies or like treatment options and things like that faster. And so like if a danger sign was like identified, that case would be then transferred or like copied over into the application of the nurse who like sits at a higher level facility, right? And manages a bunch of these health workers at the community level. And so, like when we first designed the app, we were thinking, okay, they only need to see the referred cases, the nurses. But then when we did some design under the mango treeing with the nurses, we found that, the referrals really gives them only a very small window into seeing like, what's happening in their catchment area. Like they actually wanted to see like all the pregnant women that are like due in the next 3 months, so that they can prepare like supplies and resources at the health center. And so we hadn't really considered that in the design until we spoke to them. Like, what would you want to see? Like, what if you could have anything in this app, right? Like, what would you want? And they're like, hey, we'd love this. We'd love a list that filters that way and a list that filters in this way. And it was really awesome to have those conversations with them and then we did give it to them. We did build a version 2 of the app that sort of suited their needs. And, ideally what happens is when you do that, like the adoption of your apps and the success of your app, like, improves. People adopt, people start using it.
You're describing a process that I talked about in a couple of episodes ago. It's with a guy named Dustin Homer of Development Gateway, basically, where it's the feedback loop, back to the person on the ground, right? So often we've been guilty of the premise or the implementation of asking somebody to collect data, get it, but then never giving it back to them, right? And more importantly, when you give it back to them, are you actually giving them stuff that they can use? It's important to them so that they're part of that process. That's great to hear.
Exactly. Yeah.
So as you're sitting under the mango tree and you're sort of visioning what happens, what's the next, let's say, 5 years look like for Dimagi? And like, how do you see your service growing or changing or evolving to better serve the needs of your constituents?
Yeah, so it's a great question. So, like a lot of our projects right now are scaling nationally. So in Senegal, we have a supply chain project that's scaled nationally in Senegal. India, where we're deploying apps to a large number of health workers nationally. Guatemala, Malawi, all these countries, right, are scaling our software at the community level, like at a very large extent. And so you're seeing governments and NGOs and donors investing in this infrastructure and putting out all these apps to health workers and whatnot. So in the next 5 years, what we would want to be doing is investing in functionalities and processes that help us gain the sort of ROI on all the investments that we're all making, right? And so what's the next thing beyond supporting the frontline worker? It's thinking about the frontline workers' supervisors. Right? So we've automated to a great extent, like the workflows at the community health worker level, right? Through checklists and, job aids and multimedia and videos and whatnot. And so we're improving the quality of care at the front line, but how do you improve the quality of just a program generally? And so you need to think about automating supervision. We need to think about, better ways of measuring the quality of the data that's coming through, right? So sometimes there's health workers that might sit under the mango tree and just enter data, but they're not actually making consultations, right? That happens.
That never happens. No, stop that.
So how do you automate trying to understand data quality, right? And you mentioned feedback loops, right? How can we innovate in order to close those feedback loops so that health workers themselves get the feedback themselves, right? We've done some experiments where, we've given graphs to health workers that automatically show them kind of how they're performing compared to their peer group in their region or something like that. And so that is truly motivating for health workers in some cases, right? So they're able to see that they're not doing as many follow-ups or consultations as their peer group, and they're then motivated to do more, right? And so that's an interesting innovation. So we want to try to look into those things and also make them configurable and available to our project so they can add that, to further enhance the quality of their program in general. We've also done some experiments on the data quality aspect. So we've looked at outlier information. So if we're expecting that in this particular region, the rate of diarrhea or something like that within children of 0 to 5 years is this percentage, then if there's something that's off in the data that's coming in, maybe that's something that we should investigate. And it could be an outlier, it could be a real thing, but if we can automate things like that, then I think it'll immensely improve the programs in general. We've gone to a great extent automating supervision, actually. And so you can imagine if there's a number of health workers that are using ComCare apps for tracking children or whatnot. We have a facility now to be able to build supervisor apps that kind of pull information from all the health workers that they manage into their app. Right. And so that's all automatic. Right. And so it's great because now the supervisor is able to dynamically follow up, and they can instead of just now how supervision works often in community health worker programs is they just sort of decide I feel like going there, or I haven't seen X health worker in a long time, so I'm just going to go see her today and follow up with her. But now you can dynamically and in a data driven way do supervision, so you can go and see the health worker that's struggling the most or hasn't submitted the data in a long time, and so you're doing supervision in a more smart way. Those are the kinds of things that we want to automate, I guess, in the next 5 years.
How does all this happen? I'm just thinking, my next question is usually about what kind of disruption that you've seen in your particular field over the last couple of years. And I want to ask that question, but I want to characterize it as, the apps that you're talking about seem fairly complex. They're smartphone driven. These are, I'm assuming it's more than feature phone, right? And so what's enabled that, or what disruptions have you seen that have allowed ComCare to flourish in these areas?
Where disruption as in new technology, perhaps, that where like
Yeah, I'm
things that we're
thinking,
doing. Yeah.
is it internet.org? Is the fact, is it a data pipe availability? Is it just sort of the fact that people have access to mobile networks where they can use it? Or, have the cost of feature phones and smartphones come down enough that you're able to reliably provide this to people and know that
Yeah.
they can download it, because, you've moved beyond SMS?
Yeah.
Like, what is it?
I think where we're likely to see disruption, where we are seeing disruption now, is that as we have more and more coverage of our apps using, of health workers using our apps, there's economies of scale to be had, right? Like, so maybe we start building a maternal and child health app, but then, obviously this health worker isn't just delivering services to pregnant women and children. They might be delivering, other services like family planning services or nutrition services, not just newborn care, but like nutrition up to 5 years of age or whatnot. And so what's amazing is that once you have the infrastructure laid at the community level, you can add new programs and new modules for a relatively small cost over time. So then we're really showing that once you invest upfront, there's potential for expansion across these different verticals in the health system. And so that's one way where we're seeing like some massive opportunity like for scaling systems in a very harmonized way. We're also pushing the envelope in terms of integrating our apps with other point of care like diagnostic tools. So like connecting CommCare to like, a peak flow meter, or connecting CommCare to some other like, fingerprint scanners or other tools basically, which is pretty exciting. And so, or like, calling out from our app to another app that might monitor heart rate or something like that. And so the apps are getting more and more complicated, and it's pretty exciting to see like us doing integrations with these other softwares and other tools as well.
So you've taken me to the next place I want to go. Who's responsible in your organization for sort of identifying these new touch points in these areas of growth and what we often refer to as innovation, right? So how does that happen within Dimagi? And you've talked a lot about the community sourcing, right, or the crowdsourcing of information, but then of looking at what your user needs are. But who's then at the other end of the phone watching that data?
Yeah. So I think in terms of how innovation gets pushed sort of within Dimagi, it's quite interesting because we're a smallish company, like we're 100 people about all over the world working on all these projects. And as I mentioned, like Team Sat is like the second value. And the people on our teams kind of come from a very diverse range of backgrounds, aerospace engineers to like, public health experts to water and sanitation experts, or like engineers, people from the social sector, private sector, all the range is very different. And where I'm going at here is that really the innovation kind of is driven by the individuals at Dimagi in many ways. So like, there was a colleague of mine who was like super excited about breaking into this private sector and seeing kind of how our tool can be used by small to medium-sized enterprises, because they also have similar case management needs, right? So you can imagine like a small enterprise that is selling solar chargers or water filters in some region, and they have a sales force, that's sales and like following up with clients and like collecting payments and whatnot. And that small business needs an application as well. So like he kind of spent a year or so like figuring out the market and like making it happen and building a template app, and then kind of working with all these SMEs like trying to use CommCare apps. And it's been pretty exciting. So like he really led that, and he was really excited about taking Dimagi in that direction and made that happen. We have a colleague that's an agriculture expert and like has been spending a significant amount of time understanding how our tools can add value in the ag space through SMS, through mobile apps, in whatever form. And so it's been pretty exciting to like have him be like our ag expert, and I think before he joined, like we knew that there was opportunity to add value in the ag space, but we aren't able to really move that far along the chain. And even in education, so we have a couple people at Dimagi that are like super passionate about the value of ICT in education and so on and so forth. So I really think that it's amazing to work for a company where really the individuals that come to our company are like truly driving kind of the different sectors and spaces that we expand.
How does all of this get funded? You're a B Corp, and there's a profit at the end of that sentence. So are you funded traditionally, or are you charging for the service? How does it work?
We're funded largely by donors. So, we're looking at like Gates Aid, NORAD, NORAD, and other groups such as that. And then, so either, directly or via our partners, which are often NGO partners. So, they're implementing, services that are in line with the ministry's strategic priorities or whatnot, and funded by donors. And so, they pay us for our software services and our services to build apps and manage projects and whatnot. And then we also have like at least one, if not more, agreements directly with ministries, which is really cool. So ministries are, we're working with the Ministry of Health in Senegal and directly, and that's a really cool thing. So our clients can be ministry in some cases, and then finally, like the work that my colleagues were doing for the private sector engagement, like in some cases we do have these SMEs paying us monthly hosting fees as well. So it's a range of places where our funding comes from.
And are you able to, I was interested, I did not expect to hear you say that you were mostly donor funded. Are you able to peel off some of that funding for instance, you said you have your agriculture expert looking for ways the app can work in ag, and the business and the SME expert. Are you able to peel off some of that funding to continue to be forward looking about new product development, or how does that ultimately get funded? Is there continued investment from somewhere?
Yeah, that's a good question. So sometimes we have core funding to support and develop our platform. And then if there is a partner that comes to us with a project with fairly complex requirements, and they're willing to sort of fund new features, then sort of through that avenue, like we develop like new product features and whatnot. And what's great about us being open source is that those features are then available to all the other partners, even if like they hadn't actually been the initial one to invest in that feature. So like a lot of our bigger projects often end up kind of driving forward a lot of really new developments in our platform, and then that sort of trickles down to like everyone else that uses our platform. And in that sense, CommCare is constantly evolving, and sort of the benefits of that evolution are kind of experienced by all of our partners that are existing users.
So you said a few minutes ago that you have a couple ministries that are direct clients. They hold licenses with you and whatnot. Have you had a moment yet where your platform has become a standard op, or it's a two-part question really, where the platform's become a standard op, or were some of the evolution and some of the work that you're doing with the community health workers, for instance, you were saying how they said, hey, let's take the list and go from 15 to one thing that we discuss. At what point did they turn into sort of, hey, this is how we operate, rather than just figuring it out? Does that make sense?
Yeah. It's really hard, right? Because I think we're a pretty complex organization. So like, there's the platform, right? And then there's the apps, and you can build N number of apps on our platform, right? In any N number of sectors, right? And then there's like new markets or new models that we're trying to adapt our software to. And so like how innovation across all of these areas kind of becomes a standard op is like it's a really hard question to answer. Does that make sense? Like why that's a tough one?
Yeah, sure.
But
I guess so I'm thinking about that. It's just like, let's think of the App Store, or the Android Play Store, right? Where it can become an overwhelming menage of things, right? So if I'm a community health worker, I'm somebody who's in a country where you're not currently implementing anything, and I roll up to the App Store, I'm like, where do I start? Is there a way for you to curate that, or?
So yeah, I think if we focus on the application aspect of it, the second thing I mentioned, then I think definitely there's like a lot of stories there that I can share. In that, oftentimes, health worker programs, or even like ag programs, in fact, like have a pretty standardized workflow. So let's take India, for example. In each state in India, health worker programs are run pretty much the same way. It's one country. Each state has like their own priorities, but more or less, the type of work that health workers do is like pretty standardized. And so, we're developing a standardized application that is, has, the same sort of indicators in it, and same workflow, similar checklists, but maybe in different languages. And so, we've vetted the requirements with each state, but like essentially each state, will have a standard tool that they'll use, and that's what allows for, scalability and replicability in an immense way. We may even work with a number of organizations in one country that want to do a similar workflow. So let's take HIV or TB, for example. Like one partner might want an integration with like a diagnostic tool, one partner might want some additional web dashboards, one partner might want something else. But like essentially what we try to do there is we understand that the ministry in that country has a pretty standard protocol for tracking HIV and TB, indicators and delivering HIV and TB services. So what we'll try to do is convene with all those groups and stakeholders, including ministry, and identify what are those key requirements and build that standard app. And then we'll do the customizations for each partner working in each region, separately. But like we're starting to get it actually into that space where within apps, we're trying to see like what is the core, standard template, and then what are the customizations that need to happen after that. And what's great is like as we have these templates defined, it really allows for organizations and health programs to adopt the tools faster because, the standardized tools have been vetted and they've been tested and, improvements are made over time on them. So they're really, by the fifth version, they're getting like the fifth implementation, they're really getting one of the best versions of that app that they can get. We actually did this recently in West Africa where we developed a nutrition application with World Vision, and we started off in Niger, and we ended up making the adaptations that are necessary for tracking, malnourished children in Chad, in Mali, and we made those adaptations, but essentially the application was based on this core standard app that was made. And that really allowed the program to scale quickly across those 4 countries in their nutrition programs. So it takes a lot of work and it takes a lot of convening with partners and like getting everyone on the same page and like, making sure that these protocols are in line with what the ministry wants and are in line with what World Health Organization requirements are, et cetera, et cetera. But it does have a long-term value in terms of sustainability and scalability for sure.
I wanted to just reflect on that very last little section that you just described there, where so often we are attracted to the illusion that a technological solution will mean less work. And ultimately what I think we're finding, or the reality is not only does technology, you just said it's convening, it's building consensus, it's finding, what are the right requirements for each ministry or each situation, but then, then adapting the technology to that. And so this is me sort of just on my little soapbox here saying that we're seduced by that thing. It's like, oh, hey, we're going to create an app and that's going to make everything better. But really, it's ultimately these are living, breathing organisms, these technology products, and they need to constantly be fed with, humans that are guiding them along, right?
Yeah, for sure. And, what you just said there makes me think of some of the work that we're doing around what we call the maturity model. And I know other ICT for D groups are also looking into things like this, but we've developed this framework that tries to get organizations to like crawl, walk, and then run when they're implementing
absolutely sure of course.
Apps, because oftentimes, like you said, like our clients come to us and say, okay, they want a mobile app for whatever program or whatever workflow or whatnot, and then it's not as easy as just going to the Play Store and downloading it on your phone. Not at all. Like, you need to ensure that like these health workers are first off trained on the content, right? Like you don't want to drop in an application without any training on it. So you need to make sure there's training. You need to then make sure that it's clear what happens if the application gets deleted. What happens if the phone breaks? We've had tons of stories where like like a health worker is like cooking at the same time as like, like using her application, and then, it falls in like, boiling pot of hot water or something and then breaks, so like what happens when like the tool gets broken? And so like these technical backstopping structures and whatnot have to also be in place, right? Like it's just not the mobile app itself. You're not done once you like train the health worker on the mobile app. There's so much more. The piece that we really want to invest in now and are investing in now is like data-driven management, right? So like, one of the biggest promises of mobile apps is that, okay, you're going to get real-time data, but like, that's fine. Data is going to come into your server because health workers will be entering the data after training, but like, what are you going to do with the data, right? Like now you have all this data, how are you going to make decisions to improve your programs? And so, you need to sort of achieve a certain maturity, right? In order to end up having the impact that you hope to have. And so there's all these other things besides the app, and our maturity model framework captures that, right? So like we have all these different areas that you need to also be strong in order for your program to be sustainable. Like it can't just be about the app. At some point, you kind of have to stop thinking about the app and think about these other capabilities and processes and skill building within your organization or within the ministry that you have to prioritize in order to, keep your program sustainable and actually delivering the impact that you intended to.
Two more questions for you, and these are my secretly my two favorite questions. It's your moment to geek out for a bit, and
Super.
You get to sit in Senegal. You're highly immersed in your organization and the projects that you deliver, but who do you pay attention to for new ideas, cutting edge stuff, things that help you to continue to push Dimagi and the work that you do?
Yeah, that's a great question. So, I'm out here trying to build one of our latest regional offices. So Dakar, West Africa is the latest and the newest office. And so a lot of my time spent is focused on building my team and like their professional development and like our strategy going forward and like, really setting up a strong team, strong leadership. And so like a lot of the things I read is HBR. I really also like Seth Godin. He's like a marketing guru.
Sure,
I think he has a lot of innovative and interesting ideas and always inspires me. Somehow I'm always able to link what he's talking about to my life or my work. I also love, the podcasts, 99% Invisible. I love things about design and product design and kind of how things came to be. And so I love listening to that podcast. Freakonomics is also quite interesting. I think I listen to like a Freakonomics podcast every morning before getting to work. And yeah, like I also, if I tell this to my friends, and so I'll say it here, but if I lost the internet and I could only have like one website that I could keep, I think I'd keep Brain Pickings. I'm not sure if you're aware of that, but it's a beautifully curated.
I am not.
Yeah, it's a beautifully curated website with articles about life and just philosophy and all this really amazing stuff that I would highly recommend you all sign up for.
Super cool. All right, so final question: thinking outside the Dimagi world, the work that you do every day, is there something out there that you've seen in one of these blogs that you follow, or one of the podcasts that you follow, or somewhere else? Is there an innovation out there for the development and humanitarian aid world that you're particularly excited about or think is just super cool?
Yeah, let me think about that a little bit. There's so many ideas out there. Well, right now, like something that I'm trying to figure out is how to turn the paradigm of development kind of on its head, in the sense that often what happens is, programs kind of decide what content health workers are going to get in their apps. And what I'd love to see happen is that health workers and communities decide what content sits in their mobile apps and really try to make it pull-based, versus largely our work is push-based right now. So some of the stuff I'm reading online is like, how do you develop really authentic and impactful pull-based applications, especially for like our kind of user base, right, which is often low literate in low resource settings. And so that's kind of what I'm trying to figure out right now. Like, what happens and can we do more design under the mango tree and like actually have communities choose the social, content that they want to see. And then we respond to that, demand and co-create that content with communities and whatnot. So yeah, reading a ton about product development around that line.
Mohini, thank you so much for taking the time to be on the show with us today.
Good to be on here, Stephen. It was super fun.
You've been listening to the Terms of Reference podcast from aidpreneur.com. Subscribe to us on iTunes.